Hello dear students, today we are going to learn a clinical vignette on osteosarcoma. A 15-year-old boy is brought to the pediatric orthopedics clinic by his parents due to a 2-month history of progressively worsening pain in his right knee. He describes the pain as a deep, continuous ache that initially only bothered him after playing soccer, but is now constant and frequently wakes him up at night. He denies any specific history of trauma, fever, chills, or unintentional weight loss. On physical examination, his vital signs are normal. There is noticeable swelling and a palpable firm tender mass over the right distal femur. The overlying skin is slightly warm with prominent superficial veins. His, his range of motion at the knee is restricted due to pain. Initial laboratory features include normal WBC count, normal ESR, increased alkaline phosphatase, and increased LDH levels. So from this clinical picture, what we have a young boy with 2-month history of painful swelling in his right knee, and there is no history of trauma, no history of fever, chills, or weight loss. And on examination, we have a large palpable tender mass over the right distal femur with overlying skin is showing the prominent superficial veins and is warm on touch, and his range of motion is reduced. So this swelling is less likely to be infectious, less likely to be associated with trauma. The most important differential diagnosis of such swelling, which is at the distal end of the femur, and there is no history of any fever or inflammatory markers are not elevated, then always think of osteosarcoma. And from the laboratory features, what we have no sign of inflammation or infection because WBC count and ESR levels are normal. Alkaline phosphatase is increased, although it remains on higher side in young growing children, but it is also increased in cases of osteosarcoma because it is secreted from the osteoblast. So any lesion which can cause the activation of osteoblasts or formation of new bone will lead to increase in the alkaline phosphatase levels. Another marker is LDH, which is a non-specific tumor marker which is commonly elevated in conditions like malignancies including the osteosarcoma, lymphomas, leukemias. So it is just a marker of high cell turnover. So it is also a non-specific marker of osteosarcoma. Now come to the further investigations. The X-ray AP view of the right knee joint is showing the distal end of the femur with a mass, and this mass is causing the periosteal reaction in the form of sunburst appearance. There are two types of periosteal reaction in osteosarcoma. First is the sunburst and second is the Codman triangle. Codman triangle is the formation of a new bone. This is the periosteum, and when this tumor grows rapidly, it will elevate this uh, periosteum and causing the deposition of new bone in this region, and this is known as Codman's triangle. It is a sign of aggressive tumor and it is not specific to osteosarcoma. It can also be seen in other aggressive tumors like Ewing sarcoma. So sunburst appearance, which is the classic feature of osteosarcoma, can also be seen in other cases, also seen in Ewing sarcoma and metastatic bone tumors. And in benign conditions like aggressive osteomyelitis, it can also be seen in those cases. So these two signs are just the periosteal reaction, nothing else. These are not specific to osteosarcoma. Further investigation include the core biopsy from the tumor mass, and it showed the presence of malignant cells. These cells with high NC ratio, you can see the nucleus, dark nucleus with high NC ratio, and they are producing the infiltrating the normal bone, destroying the normal bone, and also producing the new irregularly formed osteoid bony material without any calcification. This is the osteoid formation, and this is the classic feature of the osteosarcoma. You have the osteoid formation along with the malignant cells. Now come to the questions. A core needle biopsy of the mass is performed. Which of the following histopathological finding is absolutely required to establish this specific diagnosis? Option A, sheets of uniform small round blue cells with scant cytoplasm. No, this is the feature of round cell tumor like Ewing sarcoma. Option B, production of unmineralized bone matrix osteoid by the malignant cells. Yes, this is the classic feature of osteosarcoma, so option B is correct. Option C, multinucleated giant cells interspersed with mononuclear stromal cells. This is the feature of giant cell tumor of the bone. Option D, a proliferation of the benign cartilage forming a cap over a bony stalk. This is the feature of osteochondroma. Option E, nests of epithelioid cells forming glandular structure. This is the feature of adenocarcinoma, and it is not associated with the bone tumor, so option B is the correct option. Question number 2. If detailed review of this patient's early childhood medical records revealed a history of bilateral leukocoria, that is white pupillary reflex, requiring enucleation of one eye, he most likely carries a germline mutation in which of the following gene? Retinoblastoma gene is a tumor suppressor gene, and this gene is located on the chromosome 13q, that is the long arm of the 13 chromosome at position 14, and it encodes the protein RB, and this function as a checkpoint for the transition from G1 to S phase in the cell cycle. This activation requires the phosphorylation of this tumor suppressor gene, which leads to the release of the inhibitory effect of this protein and leads to the continuation of the cell cycle. So it acts as a stopper, it acts as a break in the cell cycle. So any mutation which causes damage to the or loss of the two alleles of the retinoblastoma gene will leads to uncontrolled cellular proliferation, leads to the tumor. So retinoblastoma is a tumor suppressor gene located on the long arm of the chromosome 13, and a defect causing the loss of the gene, and which requires the two hits because they have two alleles. So two hit hypothesis, which works in the retinoblastoma, causing the hereditary retinoblastoma, and it leads to the increased risk of osteosarcoma in the adulthood or early childhood. So the option C is the correct option. Other options like TP53 is also associated with the increased risk of the osteosarcoma, and it causes Lee-Fraumeni syndrome. Other options are not associated with increased risk of osteosarcoma, unless the genetic syndromes associated with the increased risk of osteosarcoma are: number 1 is Lee-Fraumeni syndrome, Number 2 is hereditary retinoblastoma. Number 3 is Bloom syndrome. Number 4 is Rothmund-Thompson syndrome, and number 5 is Werner syndrome. The gene involved in the Bloom syndrome is the RACQL3, and in Rothmund and Werner syndrome, the gene is RACQL4. These both genes are the DNA helicase genes and involves in the DNA replication and repairing and maintenance of the genomic stability. So mutations are associated with these syndromes, and these are the genetic syndromes associated with the increased risk of osteosarcoma. So remember these 5 important risk factors for osteosarcoma. Now come to the question number 3. At the time of diagnosis, a staging workup is performed. Which of the following is the most common site of distant metastasis of this primary tumor? Osteosarcoma metastasizes via the hematogenous route, and the most common site is the lungs. Remember, osteosarcoma metastasizes commonly to the lungs. Question number 4. Which of the following features most reliably differentiate this patient's condition from Ewing sarcoma? Let's see each option one by one. Option A. This condition affects children and adolescents, whereas Ewing sarcoma exclusively affects the elderly. No, Ewing sarcoma is also a malignancy of children and adolescents. So this option is not correct. Option B. This condition typically arises in the metaphysis of the long bones, whereas Ewing sarcoma classically arises in the diaphysis. This is the correct option because metaphysis is the site for the osteosarcoma and diaphysis for the Ewing sarcoma. So option B is the correct option. Option C. This condition presents with an onion skin periosteal reaction, whereas Ewing sarcoma presents with sunburst pattern. Actually, the Ewing sarcoma is more commonly associated with the onion skinning and the osteosarcoma with the sunburst appearance. So this is the reverse order. So this option is not correct. Option D. This condition is driven by translocation 1122 translocation, which is absent in Ewing sarcoma. No, Ewing sarcoma actually is associated with the translocation 1122. So this is also the wrong option. Option E. This condition heavily involves the joint space and articular cartilage, whereas Ewing sarcoma strictly spares the joint. No, because in both osteosarcoma as well as in Ewing sarcoma, joints are less commonly involved and they spares the joints. So both do not involve the joints. So option E is incorrect. Question number 5. A 65-year-old man develops osteosarcoma of the pelvis. He has had long-standing deforming bone disease involving multiple skeletal sites. Which underlying condition is most strongly associated with osteosarcoma in this patient? This is a very important question. It is asking about the risk factor in adult or old age osteosarcoma, and this is the secondary osteosarcoma because it occurs after a disease, and the most important risk factor for the osteosarcoma is the Pichette disease of the bone. So option B is the correct option. Other options are not associated with the increased risk of osteosarcoma. Now come to the next question. Question number 6. A patient with osteosarcoma undergoes treatment. Which chemotherapy combination is classically associated with osteosarcoma treatment? Osteosarcoma treatment requires the neoadjuvant chemotherapy, that is, the use of chemotherapy before the surgery. And the chemotherapy which is most commonly used in the treatment of osteosarcoma is the combination of high dose methotrexate, adriamycin, that is the doxorubicin, and cisplatin. High dose methotrexate, adriamycin, or doxorubicin, and cisplatin. So option C is the correct option. And after the chemotherapy, when the size of tumor shrinks, then limb sparing, wide excision surgery should be done when feasible, followed by the post-operative MAP regimen. However, in cases of localized low-grade surface osteosarcoma or parosteal osteosarcoma, a wide surgical excision alone is sufficient without need of chemotherapy. In cases of metastatic disease, systemic chemotherapy along with the resection of the primary tumor and metastasis, if feasible, should be done, especially in cases of lung mets. Unresectable disease requires the chemotherapy, radiotherapy, or palliative therapy. In cases of relapses, the surgical resection is very important if relapse is completely resectable with the need of chemotherapy as per the requirement. Let's see the other options. Option A, ABVD chemotherapy. It is used in the treatment of Hodgkin's lymphoma. CHOP chemotherapy. It is used in the treatment of non-Hodgkin's lymphoma. BAP chemotherapy. It is used in the treatment of germ cell tumors. FOLFOX chemotherapy. It is used in the treatment of colorectal cancers. So option C, MAP chemotherapy, that is high dose methotrexate, adriamycin, cisplatin, is the treatment of choice of osteosarcoma. So what are the take home messages? Osteosarcoma presentation seen in teenager with worsening knee pain and swelling with elevated alkaline phosphatase, and it arises at the metaphysis of the long bone, unlike the Ewing sarcoma which arises at the diaphysis. Codman's triangle and sunburst appearance are the two commonly seen periosteal reactions. Histologically, we can see the malignant cells producing the osteoid material, and genetics involve the RB1 gene and TP53 genes, which are involved in the hereditary risks for the osteosarcoma. And in older patients, the osteosarcoma commonly associated with the Paget's disease of the bone. So this is all for today. Thank you.